Asirvatham, Professor of Endocrinology, Sri Ramachandra Medical College and Research Institute. She did her DM Endocrinology from Amrita Institute of Medical Science and Diploma in General Medicine from Southern Railway Headquarters Hospital. She did a MBBS from PSG and she has published more than 30 national and international publications and co-authored 10 chapters for textbooks.
Reena is my close friend's daughter. She is the daughter of Dr. Asirvatham. And my daughter and Reena were classmates. So we had a closer association with her. And the topic also is a very interesting topic. Hyponatremia is becoming more and more common. The clinical settings in which it is common is one is the ICU care. Intensive care patients develop hyponatremia. And elderly patients who are living alone, especially single. They don't take proper diet, they don't take enough fluid. And even the volume status varies in such patients, which also alters the sodium levels. Over to Reena.
Thank you for the formal and informal introduction. And I thank Dr. Kumre, Dr. Adlyne and the entire Receptor team for having me here today. It's good to be back home and back again in Receptor. So the clinical scenario that I will be discussing is about a 47-year-old female presenting with disorientation and hyponatremia. So the scenario is very clear. So we are dealing with a symptomatic hyponatremia, which definitely warrants further evaluation and appropriate treatment. So I'll take you through 3 clinical cases, a brief introduction of them. We will look at the basic physiology, the definition of what we really call it as hyponatremia. We will look at the approach to hyponatremia. We'll get back to the clinical cases and try to solve them, and I'll wrap it up with some learning points. So the case number 1 is again a 47-year-old lady with disorientation and hyponatremia, complaints of extreme tiredness for the last 4 to 5 days, and presenting with an altered sensorial, nausea, very classical of hyponatremia for the last 1 day. So she also has hypertension and is already on telmisartan and hydrochlorothiazide. Her periods are regular. Her husband passed away quite recently. On examination, she is hemodynamically stable, drowsy but arousable, no dehydration or edema. Now, a quick investigation, you will find the blood glucose is normal and ABG is showing a sodium of 190. The second case is again similar middle-aged female presenting with symptoms, and she this time has a previous history of 3 to 4 episodes of similar episodes, all requiring hospitalization, gets much better with IV fluids and gets back to her work. She also has type 2 diabetes and is on metformin and vildagliptin, no CAM intake, hemodynamically stable, and we find a pale facies in this lady who's just 47-year-old, no dehydration or edema, blood glucose normal, and we find that the sodium was 118 in the ABG. Now the third case is again a middle-aged lady who presents with tiredness and fatigue for the last 1 month, a little bit longer duration of symptoms, extreme weakness for the last 3 days. She also has diabetes or metformin, no CAM intake, obesity, postmenopausal, hemodynamically stable, and examination is essentially normal. Again, blood glucose slightly high, not quite high, that could contribute to the hyponatremia, and ABG is showing a sodium of 120. So let's come back to these 3 cases after the discussion about hyponatremia. So the basic physiology that we need to remember whenever we look at or interpret a sodium value is 2 things. 1, the sodium and water homeostasis go hand in hand. So never interpret sodium alone without the context of the water balance. Always look at sodium along with water homeostasis. The second thing what we need to remember is there are 2 major factors that contribute to the sodium homeostasis. One, and the major driver, is the antidiuretic hormone or the vasopressin. Now this antidiuretic hormone is released from the hypothalamus and then it passes through the pituitary and then reaches the kidneys, the ducts of the distal fermental tubule, causing water reabsorption. Remember, the ADH main action is water reabsorption and nothing to do with the sodium per se, and that is why I said that we need to take sodium balance along with water balance. Now, there are three major drivers for this ADH release. The most important thing is this serum osmolality and osmolality. Now, what we mean by serum osmolality and osmolality is the solute concentration in the blood, which could be sodium, which could be glucose, which could be multiple other reasons. But when the sodium, when there is increased serum osmolality or when the sodium level goes up, that triggers the osmoreceptors at the hypothalamus to release the ADH. The second factor that contributes to ADH release is this reduced blood pressure or a decreased effective circulating blood volume, and third being angiotensin 2. So when these are the factors which keep the ADH release at check. The second important factor that manages the sodium is this renin-angiotensin-aldosterone pathway. We are all very familiar with this RAAS pathway, but what we need to understand is this angiotensin 2, which has effect both at the level of kidneys as well as at the level of brain. So the angiotensin 2 stimulates aldosterone production, which contributes to both sodium and water reabsorption. Remember, ADH causes water reabsorption and aldosterone causes both sodium and water reabsorption. And it also has a stimulating effect on the ADH, which again in turn acts at the level of kidneys. Now, this understanding is very important to really interpret what we routinely ask for with regards to hyponatremia, like serum osmolality, urine osmolality, and urine sodium. Now, let's get into the definition of what do we mean by hyponatremia. Serum sodium of less than 135 milliequivalents per liter is defined as hyponatremia. Of course, we classify as mild, moderate, and severe based on the sodium levels. So 130 to 135 milliequivalents will be classified as mild, 125 to 129 as moderate, and any value less than 125 will be classified as severe hyponatremia. Now, on the right side, you will see the list of symptoms that the patients can actually present with, right from the generalized fatigue, tiredness, and nausea, to even until seizures, coma, and respiratory arrest. We have a spectrum of manifestations and symptoms that patients can come to us with. Now, beyond this kind of classification, this hyponatremia can also be classified as acute or chronic based on the onset of symptoms. If you have an onset of symptom less than 48 hours, we categorize them as acute, where we will be more aggressive and more rapidly correcting the sodium. And when the onset of symptoms is more than 48 hours, we classify them as chronic, where our intervention is going to be relatively less aggressive and probably slower. Now let's look into how do we really go about with hyponatremia. So you have an initial approach where you try to figure out what has really caused this hyponatremia, and then you have a later approach where you will figure out what exactly does this patient would benefit from with regards to whether you want to give 3% saline or whether you want to just put them on fluid restriction or VAP-TENS or normal saline. So the first half would be the initial approach, where we are going to ask 3 questions to understand what exactly has caused hyponatremia in this given individual. So the first question is this a true hyponatremia? Are we dealing with a true hyponatremia, or are we dealing with a pseudo hyponatremia? So the answer to this comes from these 2 parameters. So if you have a sodium which is less than 135, along with the serum osmolality of less than 275, then you are dealing with a true hyponatremia, which actually needs further evaluation and specific management. Now, on the other hand, you may encounter patients who have pseudo-hyponatremia, who may have a normal serum osmolality ranging between 285 or 275 to 295, or even more than 295, and that is mainly because of solute excess like increased glucose, increased proteins, increased lipids, and so on. So in those cases, you would primarily be dealing and managing that entity which is contributing to the pseudo-hyponatremia. For example, if you have a patient with hyperglycemia, for every 100 milligram rise in the blood glucose beyond 100 milligram, the sodium can actually drop by 2 milliequivalents. So just like how Dr. Suresh Professor was telling about corrected calcium, we need to correct the sodium for the glucose value. Similarly, you have correction factor for triglycerides and protein as well. So those pseudo-hyponatremia, we're not going to deal with this in this particular talk. So after confirming that it is true hyponatremia, the second step is to look at what about the ADH action. Is the ADH suppressed or is it secreted in this context of hyponatremia? And how do you understand that? Is by checking the urine osmolality. Now remember that the ADH mainly does water reabsorption. So once the water gets reabsorbed, you will find less of water getting excreted in the urine, and therefore you will find that the urine osmolality or the solute concentration is going to be higher when the ADH is in action. So when you have a urine osmolality more than 100, which means there's a good amount of solute coming from the urine osmolality with less of water, then you know that the ADH is still acting, and that's going to be an ADH dependent hyponatremia. On the other hand, if you find the urine osmolality less than 100, you know that the ADH is not in action and ADH is suppressed. So by answering the second question, you identify whether the ADH is in action or not in action. The third question is, what about the intravascular volume? Do we have the RAS pathway activated or quiet? Now, to understand that, identify that, we need to check the urine sodium. So the urine sodium is mainly checked to see if you are having an aldosterone action, where the aldosterone's main action is sodium reabsorption. So when there is a significant sodium reabsorption with aldosterone action, you will find that there is a less amount of sodium that is getting into the urine. So therefore, if you have a low urine sodium, you know the renin-angiotensin-aldosterone system is active, and when you have a high urine sodium, you will find that you think that the RAS pathway is less active. So by answering these three questions, you will understand that this is hyponatremia, and this is a hypotonic hyponatremia that really warrants further management. If you find something else, then probably we are not actually dealing with a true hyponatremia. Now, this is a very familiar chart. We would all have experienced, we would all seen in all possible guidelines. So by answering these three questions, you're almost there half step. So once you reach here, you have three reasons as to why somebody develops hypotonic hyponatremia, which could be because of hypovolemia, where we talk about dehydration and volume loss. So replenishing volume with normal saline, 0.9% normal saline, is going to get the sodium up. On the other hand, you may have hypervolemic hyponatremia, where the hyponatremia is because of dilution and because of volume overload, where you will be restricting fluids, putting them on diuretics, and probably giving them an added Vaptan if required. And these are the conditions like heart failure, liver failure, renal failure. All these conditions can contribute to hypervolemia. So I'm not going to deal with hypovolemia as well as hypervolemia. We are more interested to deal with this euvolemic hyponatremia, which is one of the most common reasons why we would encounter the hyponatremia in our clinical practice. So once you reach at this particular point, we need to understand that as the name goes by, euvolemic hyponatremia, they do not have either volume depletion nor volume excess. So whenever we are trying to put extra water or fluid or salt into the system, we need to be very careful and measure it adequately so that we don't replace too much nor too less. So how do we go about managing these patients with acute symptomatic severe hyponatremia? By saying a severe hyponatremia, we talk about a sodium which is less than 125. Some guidelines say less than 120. But however, when you have symptoms and a sodium less than 125, you may take it as a severe symptomatic hyponatremia. Now, the main role of hypertonic saline or the 3% normal saline comes in when you have acute symptomatic severe hyponatremia. And there are different guidelines that suggest different ways and means to give the hypertonic saline. But what we generally see, the recommendation is a correction of up to 4 to 6 milliequivalents per hour or two as a bolus infusion. Now, we need to actually read this guideline with caution, because what they actually do is a point of contact sodium monitoring every 2 hours. And that's practically impossible even in the best of best intensive care setups in our country. And therefore, before we really jump in and try to correct 4 to 6 milliequivalents every hour or so, I think we should be very, very careful. And I'm sure none of us do practice that amount of aggressive correction. But having said that, we need to have some numbers in mind so that we can actually plan our correction accordingly. So for acute hyponatremia or symptomatic hyponatremia, we try to correct 8 to 10 milliequivalents in the next 24 hours. Whereas in chronic hyponatremia, depending on the symptom and the background, we would probably be looking at 4 to 6 milliequivalents in a day or so. So that will be the rough number that we are looking at. The second thing is you need to actually risk stratify them based on the ODS or the osmotic demyelination syndrome, which I'll be touching up a little later, which happens because of rapid and overcorrection of saline, and that can actually cause more harm than good for the patients. Now, a couple of formulas just to make it easier for us to understand how much of sodium needs to be given for this given patient. So, if you are planning to give 3% saline for these kind of symptomatic hyponatremia, you need to know just these two formulas, which are quite easy and simple to remember. So, when you give 1 liter of 3% saline, which contains 514 milliequivalents of sodium, you use this formula of infused sodium minus the serum sodium of the patient divided by total body water plus 1. So the total body water I have taken as 40 because this is a 47-year-old lady, and plus 1. So that gives you about 9.6 milliequivalents. So if you give 1 liter of 3% saline for this lady, she will be increasing her sodium by 9.6 milliequivalents in the next few hours in which you are going to give that 1 liter. Now we need to spread it across 24 hours. So you divide that by 24 and therefore you will be correcting about 0.4 milliequivalents per hour, and that is what we are primarily looking at. Now that we know how much of volume needs to go in, we need to actually identify the infusion rate also. So the infusion rate is given by weight into 0.4, which we have calculated, and that comes about 24 ml per hour. Now we need to remember that this calculation can many times overcorrect the sodium even up to 20% of cases, and therefore it is always better to calculate and slightly go down with the infusion rate. Now, once the fluid restriction fades, or once you give 3% saline and treat the acute hyponatremia, if you really want to maintain the sodium levels, especially in patients who have other underlying diseases like pneumonia, malignancy, and multiple chemotherapy drugs that can contribute to SIADH or syndrome of inappropriate ADH secretion, then you may consider Vaptans, which are nothing but vasopressin antagonists, which primarily block the ADH action and reduce the water reabsorption, therefore improving the sodium level. So they can be given at 50 to 30 milligrams per day, but one thing that you need to remember is you always use it with caution, or probably never use it when you are putting the patient on fluid restriction or 3% saline. Because when you are giving fluid restriction and 3% saline and then adding on Vaptan, you would definitely end up correcting more, causing more problems. So never ever combine 3% saline along with Vaptans, and it is generally recommended not to give Vaptans for more than 30 days, and it's of course contraindicated in liver failure and cirrhosis, so we need to keep that in mind. So coming back, what happens when you undercorrect and what happens when you overcorrect? Now acute hyponatremia, as I told you, we need to treat a little bit more aggressively, but even then, if you treat more, you may overshoot and cause hypernatremia for the patient. And if you undertreat or don't treat, then the patient might succumb to cerebral edema, seizure, brain hemorrhage, and even death. So we need to actually walk a tightrope when you are really treating acute hyponatremia. And chronic hyponatremia is no exception. Again, when you don't treat, there is a risk of osteoporosis, serious symptoms like gait instability, cognitive impairment, high risk of morbidity and mortality. On the other hand, if you overtreat, because of the shift in the fluid, that can actually cause osmotic demyelination syndrome, what was previously called as central pontine malmolysis, where patients can develop Parkinson's, quadripensis, and even death. So, walking on a tightrope, choosing the patient who would benefit from fluid restriction to hypertonic saline to Vaptan becomes very, very crucial. Now let's come back to this patient, case number 1. So if you look at the parameters, this is a lady who presented with a subacute onset or a short duration of symptoms with hyponatremia. And looking at these labs which we routinely ask, let's look at those 3 steps. So the first step, is it true hyponatremia? Yes, it is true hyponatremia because the sodium is low, serum osmolality is low. The second question that we asked is the ADH in action? Yes, the ADH is in action because you will find that the urine osmolality is more than 100. The third question, how about the RAS? The RAS is again active because you will find that the urine sodium is 46, which is higher than 30. So given the fact that there is an ADH action, the diagnosis will go towards the SIADH or syndrome of inappropriate ADH secretion. So on further probing, this lady comes up with a history that she has been on escitalopram for 2 weeks for the depression after her husband passed away, and that teaches us the diagnosis of SIADH, possibly because of the combination of both the antidepressant and the thiazide diuretic which the patient was already on for hypertension. So whenever you have a subacute onset of hyponatremia, always think about drug-induced, and only these history can be elicited with a much more questioning, because patients many times, especially when they're taking antidepressants and antipsychotics, they don't come up with the answer right at the beginning. So there's a huge list of drugs and causes of SIADH. I'm not going to go into details, but potentially every other drug in every other specialty can cause SIADH, which we need to be aware of. The second case, again, we talked about this lady with recurrent episodes of probable hyponatremia, hospitalization, and requiring IV fluids. Again, when you look at the labs, you will find that the serum sodium was low, serum osmolality is low. Again, it's a true hyponatremia. The urine osmolality is more than 100. Yes, the ADH is in action. The urine sodium is 54, which means that the RAS is not very great. And therefore, again, thinking with going back to the history and digging deeper, this lady comes up with a history that she had menopause at the age of 34 following her last childbirth with significant history of PPH and lactation failure, and that makes us think about a possibility of hypopituitarism. So getting the pituitary panels, you will find that the patient had low cortisol, low TS, inappropriate normal TSH, low free T4, low FSH and low prolactin, clearly pointing towards hypopituitarism. And this happened to be a patient case of hypopituitarism due to Sheehan syndrome, where there is anterior pituitary hormone deficiency. And this is no surprise that patients do come with recurrent episodes of hyponatremia, every time getting better with sodium correction and never are being evaluated for the etiology. So in these patients, whenever they are treated with hydrocortisone supplementation, we need to be very careful because we often do not treat them with 3% saline or fluid restriction, and just by replacing hydrocortisone, especially at low dose of hydrocortisone, the symptoms recover and patient's sodium also gets back to normal. So the last case is about a little longer duration of history of tiredness and fatigue with extreme weakness. And this is the labs. You will find that the sodium is low, serum osmolality is low, urine osmolality again low. Now, compared to the last two cases, you will find the urine osmolality to be low. Then you know that the ADH is quiet, ADH is not in action. The urine sodium being low, and then you know that the RAS is high. So these kind of patients, we need to again go back to history. And this lady came up with the water therapy, which is very popular nowadays for weight reduction, where this lady started taking 6 to 7 liters of water per day, and that is again causing the ADH to be suppressed and causing a dilutional hyponatremia. So once these kind of patients, you restrict the fluids, this is a form of psychogenic polydipsia, and most of them present with mild to moderate hyponatremia, and we also need to rule out an underlying psychiatric illness, especially it's very common in patients with schizophrenia, and therefore these kind of patients have to be treated with the primary etiology and not just correct sodium. So the learning points from these kind of cases is that always interpret sodium levels in the context of water balance, never separate sodium from water. The second important thing is water excess is the most common reason why somebody is developing hyponatremia, and therefore we need to assess the water intake and also look at the urine output before we really make a diagnosis. Acute symptomatic hyponatremia, of course, has to be treated without much delay, even with 3% saline, with good calculation, frequent monitoring. The chronic asymptomatic hyponatremia, we don't have to actually put them on aggressive correction. We just have to monitor them, make a slow correction, and that would be fine. And monitoring again is important. The most important thing is hyponatremia is not a diagnosis. It's one of the findings of the underlying etiology. Therefore, identifying the etiology and treating the etiology will only help us to avoid hyponatremia in the subsequent disease. So thank you very much. And as you can see here, this is a tug of war between sodium and water. Never separate one over the other, because once you treat sodium and not consider water, both is going to actually cause more harm. So thank you very much.
The topic is open for discussion. It was a wonderful presentation.
I know it's late in the evening, and we know that always hyponatremia is not a topic that we all really like in a sense. It's a tough topic and well presented. Thank you, Dr. Adlyne. And it was very clear and concise. Thank you. And I would like to invite Dr. Gayatri to felicitate our speaker.